Hello, everyone. This is Rosie Tlaga from Becker's Healthcare. Thank you for joining us for today's webinar, From Promise to Practice, AI in Clinical Decision Support Only Works When Trust is Built In. Before we begin, I'll walk us through a few quick housekeeping instructions. We will begin today's webinar with the presentation, and we will have time at the end for an hour of at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and it will be available after the event. You can use the same link that you used to log into today's webinar to access the recording later. If at any time you have any issues with audio or visuals, please try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. With that, I am pleased to introduce today's speakers. First, Dr. Scott Nelson, Program Director of MS Applied Clinical Informatics and Associate Professor of Biomedical Informatics and Clinical Director of Health IT at Vanderbilt University Medical Center. Second, Fabian Wecker, Senior Clinical Consultant of Client Success at Micromedex. Dr. Gavin McNatt, Clinical Consultant of Pharmacy at Micromedex. Angela Anderson, Senior Director of Content Optimization and Innovation at Micromedex, and Dr. Dennis Dansby, Vice President of Healthcare Technology and Informatics at Tampa General Hospital. Thank you, Scott, Fabian, Gavin, Angela, and Dennis for being here today. I will now turn the floor over to Angela to get us started.
Thank you very much. And we're very happy to be here and share some time with a panel discussion for you this afternoon. The goal of this webinar is going to be to share some insights into AI's role within clinical decision support. I'll give you a feel for what's going on across our different panelists' experience and what they're seeing out in the environment today. Provide some actionable strategies to critically assess and adopt AI tools safely, and also to discuss, how to build trust with AI-enabled decision making. So have a conversation around that. So that's kind of the goals for the session. There've been a lot of webinars related to AI lately. It's a very hot topic. We're happy to join it in as well. But AI isn't new. It's not a new technology. It's just kind of really come straight to the forefront with all of the excitement around generative AI most recently. But it has been around since the 50s, actually. So it's not something new, but it's something that's continuing to emerge and emerge more quickly. A lot of the challenges that we're running into is looking at, how are these systems being created? How are they being validated? And we're looking around these opportunities for how can AI enhance clinical decision support rather than replacing. So to kick us off, I'll start with you, Gavin, from my team. What excites you about AI potential in clinical decision support right now?
So, thank you, Angela. I really think that the biggest opportunity is in healthcare to take large amounts of data and synthesize that into snippets that we can digest quickly, whether it's between rounds and seeing patients, whether it's in clinic, just being able to take the depth and breadth that medicine is known for and really synthesizing that into those digestible bites. And so I really am excited about that opportunity, not only for clinical decision support, but just for clinicians in general.
Yeah, I mean, it does seem like it's got a lot of potential. We've also, I've been out talking with several different customers over the last few months. There are gaps. So there's gaps in organizations as far as being ready to adopt clinical or AI for real world clinical use. There's a whole lot of excitement and buzz out in the industry, but there are some gaps out there as far as organizational readiness. Any gaps in particular, Fabian or Dennis, that you've seen in your experience as you've been encountered?
I'll take the bait, Fabian. On that one,
go ahead, Dennis. Yeah.
I'll mix in a sense of humor as well. I would say our gap is on the adoption side. I think it's a lot of times it's the speed at which providers, and when I say providers, I'm talking generic pharmacists, nurses, and docs, are moving at. In the idea that, hey, we're implementing a new tool that getting the message across that that tool is going to make them more efficient, and that we're not there to kind of replace them or kind of, replace them, I think is the word. We're trying to make them more efficient and kind of sell that story to them. Sometimes we get involved with kind of testing as well, but oftentimes, that message is not really picked up well. And sometimes just the adoption of the tool, even though we may save you 15 minutes a day, spending the 5 minutes to show the tool is not worth it. So adoption is just super, super difficult, I would say.
Yeah.
Yes, and I
Go ahead, Fabian.
Go ahead, Andrew. Yeah, I was just going to say, I was, to add to what Scott just said, I think, regarding the gaps, I think sometimes the perception of a lack of data quality or availability of data is something that, is sometimes coming up. And how do we actually how do we process the information? That lack potentially of explainability about how we go from point A to point B is something else that often comes up, and that clinicians I'm talking to all over the world are bringing up as well. And so I think those are, mindful. It's mindful bits of information that we need to be cognizant of, and to actually make it so that it does not replace us, like Scott was hinting at, but that it actually helps us augment the level of data we can work with and how we can process it.
Yeah, I think one of the other gaps that I've seen is there's AI literacy when you think about it. A lot of us who've been clinicians for a long time haven't been educated in what it can do, what it can't do, what are the use cases that are actually useful. And so there's a lot of opportunity there, I think, too, with bringing the team along with education on what exactly AI is, what it isn't, and how it can be used. So,
I would also just add to that one of the gaps that I see is the gap between clinical practice and the technical teams developing the models, and that a lot of times they don't have the clinical experience and how this translates to, or how we're going to implement this into the workflows. And so making the jump from, we have this cool tool that performs really well in like a controlled laboratory setting, to how do we implement this into the workflow? How do we gain trust and experience with it? How do we get evidence of the efficacy of this new tool? That still also remains a gap. And part of that gap too, I think, is there's also a gap between the clinicians and administrators that fund the different projects and stuff. And a lot of these AI tools really struggle with proving ROI, return on investment. And so I think as we get more experience, as we do more pilot testing, that will help kind of bridge some of those gaps. And as we increase, like you said, the AI literacy and people just getting more experience with the technology, that hopefully can help bridge that gap too between the clinical needs and the technical tools and abilities.
Yeah, the two worlds need to come together, and that's kind of a gray area sometime on how do you make that happen. So looking at like what types of AI solutions are being brought into your, I'll start with Dennis, with your organization. What kind of AI solutions are you seeing brought into your organization?
Yeah, I'll answer a couple. Yeah, no, absolutely, great question. There's probably a lot of users on this call. DAX is going to be the obvious one. DAX is also, and I wouldn't say DAX is really that ambient listening. So it's the interaction between patient provider. And it's not, DAX is the brand name of the Microsoft product, but a bridge. There's probably a couple vendors in that space. I would say that the reason that tool has kind of moved the needle is it's measurable. We can measure pajama time for providers. I think that is something, maybe we'll discuss later, is when you talk about best practices, hey, you have to measure. Scott kind of pointed at ROI, but you have to, your problem statement when your AI is solving that, like you have to go back and kind of measure So it's, that would be one tool. MedSolve would be another one, pupil dilation. In our ICUs, it's basically a small handheld product that goes on a phone, integrates into, we're an Epic shop, so it goes into Epic. Apella would be another one that's computer vision in our ORs, where you can, basically it's OR efficiency. Think of devices or items left in the patient, so there's a safety play for that tool as well. Epic, like I said, we're an Epic shot. I think Scott is too over at Vandy. Epic probably has 15 to 25 agentic agents rolling out by the end of the year. And in addition to that, they have a bunch of AI solutions. So really, we're trying to, we have a lot of AI coming to the organization. There's 4 or 5 examples.
Okay, great. Scott, I know Vanderbilt's been kind of at the forefront with a lot of the AI work. What are you seeing in your organization?
Yeah, so we've done a lot of predictive models for years now. So like readmission prediction, sepsis, pneumonia, pediatric pneumonia, resource utilization. There's a model recently for postpartum hemorrhage prediction. So helping with that, VTE risk and so on. There's just a lot of different predictive models that have been around and also that we continue to develop. The ambient scribes, like Dennis was saying with DAX Copilot, has been a big one. Responding to patient messages through generative AI, so helping facilitate that process. Chart summarization. We're working on implementing an electronic prior authorization vendor to help hold information out of the chart to help with PA requests. So a lot of kind of in that space. One of the other things that we're also doing is looking at how do we monitor these AI tools over time to detect drift, to look at how effective they are. And it's been really interesting to look at what you measure to determine efficacy of these tools. And I think DAX Copilot's a great one because there's a lot of hope for like, oh, we're going to decrease pajama time and note writing time and stuff like that. Some of the studies that I've seen come out have shown that like it hasn't made that much of a difference. But when you talk to clinicians that are using it, it's like night and day difference for them. It just helps decrease the cognitive burden of having to start from a blank slate to write their notes, to help improve, so like improves their documentation. How do you measure improving their documentation? Provider satisfaction is a huge one that it improves, and just measuring that. And so looking at the different kinds of metrics and how do we measure if these tools are providing the value that we're hoping they're providing.
Yeah, I think that is a great point. It's interesting. There's a lot more, when we're talking metrics, some of it is really hard time savings, but that perception of cognitive burden and even just feeling like I'm doing something more effectively, there's a lot of value in that. And it's difficult to measure, but it's still really significant. We found that even with using like AI tools internally in the clinical content development process as like an editorial assistant, it doesn't save time, but it may save like some effort. That perception makes it feel better. And if there's value there, if it's bringing value to the end user as a tool. So
yeah, and I think sometimes it may take the same amount of time, but you end up with a much better product in the end.
Exactly.
Or like a much better note or response or things like that.
Exactly. And it looks like, all right. So I'm going to move to the next section. Actually, before I do, it looks like Fabian may have dropped off temporarily. Gavin, when you're out and about, what type of AI solutions are you hearing that our customers have been implementing or are working on?
Yeah, no, I think some of the biggest things out that I've seen just recently was a company that takes basically primary literature and synthesizes it in real time. They use what I would consider a concierge service to evaluate primary literature and give you a curated response. And so there's an AI component to that where it's taking those complex topics that we learn about in school, how to evaluate journals and articles and different studies, as well as guideline recommendations, and really break that down into, again, digestible bits of information to help eventually save clinicians time. And so that was something that I have seen recently. When we were at HIMSS at the beginning of the year, it was just around AI, and again, just that efficiency piece of how can we, kind of like Scott said, take notes and make templates, or really just help the providers make their lives seem easier. Kind of cut down on some of that cognitive burden, and be able to offer them some relief. Just because when we talk to other clinicians in the space, they talk about how frequently they're having to take work home with them. It's cutting into their work-life balance, and so really just making sure these tools, have the capacity to help in that aspect is probably one of the biggest things that we hear at conferences, around the country.
Yeah, sounds good. I think we're going to go ahead and move into the next. I'm going to move this to the next section of our discussion, and really looking into evaluation. So I think one of the things that we've kind of run into as we've been working with developing an AI-powered search feature at Micromedex is, how do you evaluate the effectiveness of these tools? What are the standards? What are the the bars that we need to reach? And there's kind of been a gap to a degree in the industry as far as standards and what is considered good enough, or how do you ensure it stays good enough? I know there's been some recent activity where the NCQA is pulling together an AI working group, and where CHI, the Coalition for Healthcare AI, is partnering up with Joint Commission. But I'm interested in moving to some discussions around, what would best practices be for, assessing AI tools, focusing on safety and trust, and ensuring that they're behaving as we would expect them to. Scott, I know this has been an area of special focus for you with looking at, the evaluation of AI algorithms. I'm wondering if you could kind of share some best practices or thoughts around that.
Yeah, sure, happy to. I think a lot of this is very similar to the implementation of any type of clinical decision support, even if it's not like an advanced model or whatever. But one of the first things that I always like to ask is, what really is the problem we're trying to solve? How big of a problem is it? How will we know that if we've impacted or improved on that problem? How are we going to know if we're successful? And so part of that is, if we can try to measure how big of a problem it is to begin with, then that can give us a good idea of what we're going to measure to see over time if this makes an improvement. But you don't want to just measure that one thing, but are there other like surrogate markers or other things like satisfaction or end user feedback that you can monitor also to identify new novel kinds of things. And part of that is that you want to engage with subject matter experts early and often, like as soon as you can in the process, because they're going to provide a lot of really great ideas and feedback on what kinds of things where this could potentially impact them, kinds of ideas for things to monitor. Look for if you have the data accessible. Is it accessible in that stage of the process? Is there bias? Are there biases in the data? Which in healthcare data, a lot of it does have biases. We tend to think that our data and our electronic health record is really great, but really it's just this tiny little snapshot of a person's life. And not everybody even goes and seeks care at the medical center. Trying to think through, again, with the implementation science of how are we going to get this in the workflow? Where is it going to fit? And then piloting it with a small group to begin with, because there's always going to be some new, novel, unintended thing. And if you can start small and then grow it from there, that helps. And then thinking about, again, looking at metrics, how are we going to monitor this over time to detect when it drifts? Because all models are going to drift. They change over time. How are we going to monitor for end user feedback? So that's an important piece. If something goes awry, end users are going to notice it first. And how can we keep an eye on that? And what is our maintenance plan going to be going forward? Are we going to have to retrain the model? When are we going to think about sunsetting it? If something does go wrong, what is the chain of command for addressing those issues? There's also a really helpful framework that I found in BMJ looking at future AI framework, where it was like 6 guidelines to evaluating, or 6 core principles for evaluating AI. And it's an acronym because acronyms make everything better. But future, the F is for fairness. So is it going to be equitable performance across populations? If you look at subpopulations, how does it perform there? The U is universality. So application across various different settings. T for traceability. So how transparent is this in decision making? Does it provide references or additional information for the clinicians that are ultimately responsible for these decisions to make more appropriate decisions? The other U is for usability. So clinician-centered design and integration. Is this something that's easily used? Robustness. So reliability under real-world circumstances or situations. A lot of times these tools will perform really well in the lab or in silico, and then we put it in the real world and it's like completely different. And then E for explainability. Do you have clear interpretable outputs? Not just like giving somebody a score or a number and then trying to decide, okay, now what do I do with this score or this number, but have a clear, these are next steps to take kind of thing, or clear recommendations. So those are all things I think that are kind of some best practices for implementing and monitoring AI tools in the clinical space.
Excellent, thank you. I'm going to look up that article. We love our acronyms in healthcare. So, so when we're thinking about like positioning AI and CDS as a support for rather than, you know, a replacement for clinical judgment, I think that's a theme I've heard in conversations, is that we're really concerned, like we're excited about bringing AI in to help with CDS, you know, to support clinical decision support. But, you know, there's a hesitancy that clinicians are going to rely solely on this and they're not going to use their critical thinking, or it's being brought in to somehow be their colleague as opposed to being a tool to support their roles. You know, Fabian, how do you think there's some ideas we have to ensure, like, as we're rolling these out, that CDS it's positioned as a support?
Yes, I think really, you know, to go back to something you mentioned before as well, is that whole concept of education, right? And how we can actually incorporate this within the curriculum. There was actually an article published not too long ago in BMJ, and they actually looked at I think it was in 2021, they actually looked at the ability that people have of working with AI. And they did that study with both physicians and with nurses. And what really came through is that there's a need to develop a curriculum with minimum AI competencies within the curriculum, so people can actually understand how to use it and how to understand it. And because there are those people who are very eager about adopting it, and then you've got the stragglers, and then you've got the ones who are just completely scared, like with any technology that might be out there. So I think a way of deploying it, I think, starts at the source. If we start incorporating those tenets of what AI is about early on in the education, and you had mentioned that early on in this presentation, so I think this is an important aspect. Potentially performing a needs assessment and goal setting. What can it do for you? How can we use it? And what would be the outcomes that we need to keep in mind? It's, of course, efficient, but it should also be about the health outcomes of the patient, right? How do we acquire the data, and how do we identify whether the data that we get is actually something that we can trust? You know, and I know that Scott mentioned, I think, the whole concept of Scott and the whole concept of biases and fairness. So I think this is something that definitely needs to be, looked at to make sure that the way it gets deployed, it gets integrated properly. It incorporates background or feedback from clinicians to work together in partnership with engineers, because you can develop something, but if it doesn't suit the clinician or the end user, it becomes a bit moot, doesn't it? So to monitor, to evaluate those efforts in order to deploy it, I think is a rudimentary but very necessary first step before moving forward.
So considering factors like we mentioned transparency in the data sources and validation methods, fairness metrics. Gavin, from your perspective, what does good look like?
Oh, that's a great question, Angela. I really think it starts from the top and the organization being able to, one, identify the goals that they want to achieve with the technology, and then setting up the appropriate guardrails to make sure that that's happening. So you want to make sure that you're doing, internal testing, that you have, identified the appropriate experts to help weigh in on those decisions, being able to do internal testing, and then transitioning from internal testing over to external testing, bringing in beta testers, really the whole gamut of making sure that you're taking your time, like Scott said, to bring in those clinical experts and really make sure that you're testing the limits of the learning of the AI tool and making sure that it returns the applicable resources. When it comes to the tool itself, we want to make sure that it is trusted data and that you're using an approach that will only return the information that you deem appropriate. You don't want ChatGPT pulling your data from the World Wide Web. You don't want to rely on Dr. Google to pull, clinical results for you that you may or may not be able to trust. And so really being able to not only have the appropriate steps in place to, validate the information, but then actually validating the technical information itself. And so making sure that you have those pieces in place is the most important metric, in my opinion, that you can take in that process.
Yeah, that makes a lot of sense. Scott, I was thinking along this line, are there some key indicators that you look for that would, let you know or feel like the AI tool is ready to be used within a healthcare setting? Are there certain indicators that an organization looking to adapt should be thinking about?
Yeah, so I would say that for the predictive models, there's some very common metrics. So if it's a regression problem, you look at the RSME or classification, you can look at confusion matrix and recall precision and all this other stuff. With the generative AI models, there are scores that you can look at to determine performance of the model. But again, I think a big part of this is also the user feedback of how well the system is working there. One of the things that I kind of alluded to before is at Vanderbilt, we're trying to build out this concept called algorithmovigilance. And so like a drug coming to market, there's a lot of research that goes into it for its approval, and then it's released into like the real world. And then we have pharmacovigilance to determine like, okay, what is the efficacy of this drug over time? Are there new side effects or things like that? I tend to think of these AI algorithms like medications, that we can have really good metrics and validation, training and testing. They look great. And then when we go to implement, we're going to get different performance out of the tools. And how do we monitor those over time? And with our algorithmovigilance, which just rolls off the tongue, so you can practice saying that a bunch like I have. With the algorithmovigilance, some of the things that we're looking at are like clinical validation. Does it make sense, like a gut check of whatever the performance is for this tool? The performance metrics, and I listed a couple for the predictive models. For like generative AI models, there's like the Rogue score and other things like that. But you also want to look at the clinical KPIs. So if we're trying to predict readmissions, well, what are our readmission rates looking like? Is it changing over time? Or are we actually decreasing like sepsis issues or things like that? User feedback, so gathering that and looking at that over time. And then continuing to assess for bias and fairness across subpopulations. And then any type of error or safety reporting or handling, how do we kind of mitigate those risks, or when they do happen, report them to the appropriate places. And so I think that that's an important part that's still a new and evolving area. But as we adopt more of these models, it's an important aspect that we're going to have to keep an eye on.
It's going to be interesting to see over the next few years how things, shift and change, just looking at how much things have changed recently. All right, so we are going to move now into a section because we've got several questions coming in, but we're going to move into the third part of our discussion around adoption, trust, and fit. So looking at how health systems can gauge their readiness and build trust, get ready for adoption with some of these new tools. And Dennis, I'm interested, what barriers have you seen that prevent health systems from fully adopting AI-enabled solutions, and are there some tips on or ideas on that you've seen that have worked for how to overcome them?
That's a great discussion. I would probably pick on a strategy. I don't think I've heard that from the group yet. I think Scott kind of nudged around it, but it's trying to develop I'm going to call it an AI strategy, and not probably in the way we usually look at strategy, which is like, well, this is what we're going to do, because AI spreads across the organization, but it's putting that framework in place, right? How am I going to intake AI? How am I going to govern AI when it's out in the wild, kind of, I'm going to call it that end-to-end process. What we're seeing right now, Angela, is there's a lot of competing AI. So Scott did a great job like listing all of those Epic solutions. So in that strategy framework, you have to say, where do I go first? Does Epic solve my problem, my EHR vendor, or if they can't do it or they can't do it well enough, am I gonna go someplace else and have them solve it? But I would say putting that framework in place is like paramount. And I think Scott also nudged it, having C-suite, might have been Fabian, having C-suite on your governance, meaning you have providers, you have nursing, quality, corporate compliance, legal to assess risk. And as those, within that process or intake process, you're really assessing what the AI does, how it works. We use Process Bolt, but you're really like running it through that funnel and kind of saying, hey, is this functional? Is it not functional? And then also, is it duplicative? Are we spending something that Epic's going to have in 2 years, or kind of that situation? Oh no, did that answer? Was that direct enough? Did I answer the question?
Yeah, no, that makes a lot of sense. It's interesting on LinkedIn every other day. I think I see a new startup coming out with some new tool. So having a framework to kind of say, okay, what matters to my organization, and where should we start? What problems do we really want to solve? I think helps with that kind of like, wow, look at, there's so many choices now. What do I do?
Yep, absolutely. And then also, I mean, probably the last thing is just this idea of having, and I'd be curious to hear Scott's thoughts, is this idea of having, he edged about talking about AI, kind of how you monitor it long term. But as we get more and more AI up, it's almost like you run into a cybersecurity problem. How do you monitor all of the AI that's up in the wild? Do you strategically have a separate AI team, or do you embed that in your BI team? I'd love to hear, Scott, if you have any thoughts on that topic, kind of what the long term is after it's out in the wild at the organization, kind of how, what your thought is, maybe a year, 2 years, like how strategically, how you continue to monitor within this space.
Yeah, that's a great question. And just to emphasize the importance of like setting up strong governance to review and kind of approve these kinds of things, and prioritization of what tools we're going to take in. And at least for us, like an important strong part of that is the cybersecurity assessment of any tools that we implement. And so I would say there's multiple layers of monitoring. There's the cybersecurity components of making sure that our systems are safe, and we do have dedicated cybersecurity teams that are doing that. As far as kind of monitoring longer term for all the different models and stuff, one of the things is that you get into a space of you have a lot of data, and you're trying to identify signals in that data of something potentially going wrong or drifting, or there's a change to the system somehow that maybe the model isn't performing as well as it should. And those are like the perfect kinds of questions that we would want to address with an AI model, right? So a huge scale of data, processing them, looking for signals, and then making sure that if something is detected, that we notify the right people. So that kind of human in the loop thing. So really, I would kind of vision it as AI watching the AI kind of thing, where you can have multiple layers of this, and every step of the way, always keeping in mind best practices for cybersecurity. And there are going to be some tools that maybe don't meet the threshold for that we're going to monitor them as part of a larger composite thing. There's some tools from vendors that the vendors have really good monitoring software and things for looking at the performance of their models. And in those cases, one of the things that we've been doing is just, here's a catalog of the tools that we have approved through our governance process. And for a lot of them, we have monitoring framework or a dashboard for looking at their performance and metrics and stuff over time. But some of them, here's a link to go look at the vendor's dashboard for this particular product because it's very specialized. And so kind of at least having a catalog that then you could jump out to different aspects of that where needed. I think that's one approach. I don't know if it's like the best approach, but that's one of the approaches that we've been taking.
That sounds great. So one of the other things when we're talking about, rolling out AI and clinical decision support is the ethical considerations. And there's a lot of attention on the technology and excitement over the potential, but there definitely are ethical considerations when it comes to having AI involved in any type of a clinical decision making or tools that are being used regularly by healthcare providers. So, Fabian, I know this is like ethics is a special interest of yours and has been for a number of years. I'm interested about your viewpoint on this.
Well, I think, yes, indeed. Thank you, Angela. I think for me, I've been dealing with those questions since 2006, 2007, as I was serving on ethics committee at a facility back in America. And one of the things that, I think is always important is to ensure that whatever technology we're using, that the advanced technology does not compromise the nature of human interactions that you have directly, that you have between providers and between patients. And I think that is something that is very important. And we talked about governance quite a bit. And I don't know if people are aware, but there actually is, I think, 6 tenets by the World Health Organization that has been published. I think it's called Ethics and Governance of Artificial Intelligence for Health. And they actually have a number of those 6 tenets that they are looking at to potentially dictate or advise on what to do. And so for AI to be integrated in from an ethical perspective, it needs to protect the autonomy of the patient. It would need to promote the health and well-being, human safety. We talked about pharmacovigilance a little bit, looking at those aspects that are in the best interest of the public, who will be treated under our care. We talked about transparency, explainability, and I guess, intelligibility, maybe, getting into those rhymes. I think this is something that kind of encompasses the fact that education is so needed. We need to still remind ourselves that we need to be accountable for what we do. AI may give us the answer, might provide an answer, but it's still up to us to figure out how we treat this answer, right? Whether it's a CDS tool, whether it's AI, this is not a substitute for our critical thinking or clinical judgment. And then I think as long as we understand that it needs to ensure some kind of inclusiveness of every section of the demographics, this is also important. Just because AI is going to share something about a particular condition or diagnostic or treatment, it is important to also delve a little bit further into the evidence that is presented to figure out, is it actually pertaining to the population that I need? Is it pertaining to the treatment that I'm seeking to prescribe, right? So having that inclusiveness and equity that we have that comes with AI is important. And I would say those 5 tenets would actually be wrapped up by the need to promote AI as a sustainable process, but also a responsible process. And I think what we've seen over the past, as you mentioned early on, AI has been around since 1950s. What I've seen lately, which can help potentially foster that strong ethical perspective, is to realize that people have gone from a reactive aspect when you talk about AI to being a little bit more proactive. And so this is good, but it also has a flip side, because sometimes when we get too proactive, we forget to look at some of the other features that we need to be mindful of. But I don't know if this answers the question for you, Angela. But
no, I think that was a lot. That's very helpful. Thank you. And then thinking about like what an ideal deployment process for like AI in clinical decision support might look like, as far as, you know, accuracy, explainability, transparency. And you know, I'm interested. Like I'll pick on you, Dennis. Could you describe what you would think like an ideal deployment might look like?
I almost feel bad because Scott did such a nice job explaining it like end to end early, but what he explained, I mean, was really our DAX Copilot Go Live, and I'll bet you there's a number of people on the call that did the same thing. You start with a very small group. Ideally, you might be testing with a vendor, maybe you're not. You're working through all the kinks, you develop a feedback mechanism, getting in user feedback, corrections are being made. You're really in what I'm gonna call an agile framework.
Mm-hmm.
And you're kind of marching along, and then, you know, maybe you start with a small group, 10 to 20 users, and then you're kind of exploding it out to, you know, 100 users, and then org-wide, that type of situation. But initially, you start, you know, call it small and smart, and move very quickly. And then probably the one thing I'm going to take from Scott is monitoring. I think monitoring is just something we all forget. And it's that, hey, we solved a problem, but do we go back and actually monitor to say, hey, this moved the needle, it didn't move the needle? But I'll defer to Scott. What did I fill in the blanks for me, Scott? What did I miss?
Oh, I think that's great. Great summary. And also, like you mentioned earlier, of governance, just making sure that there is a really solid review beforehand, which I think would be done before trying to deploy or implement any kind of technology. But yeah, start small, measure, piloting, and then how do we monitor and assess it over time?
Yeah, keep an eye on the horizon with what is the newer option that may be better, or may, you know, what kind of shifting or changing may this need over time.
Mm-hmm.
All right. Well, we are to the point where we're going to start. Looks like we've had several questions rolling in, so I'm going to start looking through and seeing what we can respond to. I see one here that says, and I'll let anyone in the group to kind of answer or pitch in on this one. Are health systems thinking more about AI end to end rather than point solutions? So, for example, how clinical decision support will fit into revenue cycle management? Is anyone?
I can jump on that first, I guess. So I would say, looking at the appetite of health systems on implementing AI solutions, the closer you get to the patient, the higher risk you run. And so the models are not infallible. A lot of the generative AI, you still have like AI hallucinations where it just kind of makes up information that could potentially be harmful. There's like jailbreaking, there's all sorts of other kind of aspects of these tools that can cause problems. But if you have things more towards the administrative side, so maybe on the finance billing component, on appointment scheduling, on documentation or information retrieval, or that kind of stuff, that's further away from the patient and is much lower risk. And the AI tools tend to do pretty well at that, like, not so sexy stuff of just like these are mundane, repetitive tasks. That's where it can really excel. I know there's a lot of excitement about like the clinical decision support and like these really clinical applications, but those are really, really hard, and really kind of high risk. And so I think we're going to see more of value provided by AI tools in those less risk, more mundane kind of tasks.
All right, I have another one here about governance. So what level of governance should an AI vendor expect as an institution to adopt as an adequate level of compliance and responsibility? Well, that's an interesting one because an AI vendor expecting an institution, and it definitely is, it's not all on the vendor to be compliant and responsible. It is on the organization as well. Anyone have any thoughts on this one?
Yeah, I mean, I'll take a stab and the group can kind of jump on. I mean, when I think of responsibility, like I just look at the kind of back to that last comment, like how are you looking at it end to end? And then you think about the labor hours, right? Because these products come in and like Scott alluded to it, your cyber team's sending out this request, the questions are coming back, and then you have a FTE or multiple FTEs, and it might be an interdisciplinary group that's wading through that model and the details of the model to kind of assess. So I would say it's a mixed bag. I don't know if that's a direct enough answer to that question, but the governance definitely falls on the organization, i.e. buyer beware. If there is an outcome, like, contractually, you might be able to put something in place to cover yourself. But I'm still like, my concerns are kind of that post-governance. How do you continue to monitor a couple years out? So I still think, like, our organization, we have some work to do in that space. But Scott, I think you may have some comments by your face, but I could be wrong.
Well, I think that's a great point. The only other thing that comes to mind is for some models, there's like the FDA software as a medical device that reviews and approves things. And then also just like there's some best practice recommendations from several organizations on good machine learning practices, or GMLP, that are kind of things that vendors could adhere to or to look at as far as being very robust in approaching that governance and review by the organization, because the organization, like Dennis said, is going to review these very in-depth. And if you can show, look, we followed GMLP, or there's like FDA approval or whatever, those are very helpful kinds of things.
Mm-hmm. All right, I'm sorry, somebody was saying that.
No worries, Angela. I was just going to jump into this. Is from a perspective more, from where I am in the UK, but I think having a good contextual fit is paramount. Like some institutions might want, we talked about the FDA and some other guidelines. It's important to keep in, to keep in mind that the outputs need to conform to, local guidelines, local practices, to be able to fully use it, whether it's at the state level or federal level or internationally. So I think this is something that also needs to be fully integrated to be able to allow end users to make full use of it. Sorry.
No, that's great. Thank you very much for that. Let's see, I've got another one here. Let's see. Do you have examples of how interprofessional clinical teams and technology providers have worked together on advancing the effectiveness of CDS tools? This may be a good one for Gavin or Fabian, because I can think of a few.
Yeah, no, I'd be happy to answer that. I think when you think about, even from a vendor side and in the health system side, bringing together that multidisciplinary approach to really solve a problem. And so having all of the applicable players in the room, whether it's nursing, pharmacists, physicians, all the way through the gamut of, like Dennis said earlier, having C-suite involvement, having that business-minded professional there as well to really help kind of round out that decision-making process. I think making sure that IT is there and you have people that, whether it's someone that's a pharmacist that's Epic Willow trained, or just has that EHR background and had that technology background, being able to kind of speak to some of those nuances and really help train staff is going to be huge. Being able to, take that complex data of the model, what it is, how it differentiates itself from other models that are out there and available, being able to break that down and explain that to your staff and have them know the difference is going to be hugely important.
Yes, I do agree with Gavin here. I think the interprofessional or interdisciplinary interprofessional clinical teams working on the adoption of CDS is paramount, because it needs to reflect what we're doing in the real world, right? This isn't ivory tower; it's the real world. And when I meet with customers, I always tell them, if you have a disease process, that means you need a treatment. If you have a treatment, you need to provide bedside care. So nothing works in silo. Everything kind of mingles and intertwines. And so it's important that every player, whether it's, from the nurse to the physician, going through the therapist and pharmacists and PT, OT, whoever it might be, needs to be fully integrated within what we do. And this also includes the patient and, those caregivers actually taking care of the patients to be fully integrated. So I think when it comes to CDS tools, having a focalized perspective on not only the clinical team, but also those lurking variables that include patients, caregivers, through patient education and aspects like this. All those features are very important to create a well-rounded experience for everyone using it. And to actually, so you get the most out of it from an ROI, not just financially, but also professionally.
Thank you very much. I have one other one. I think we're getting close to time, but this is an interesting. So how should clinicians approach AI tools that cite conflicting or outdated medical data? And I think this might be speaking specifically about some of the decision support tools that are out there right now, I've tossed this out. Anyone have any thoughts on?
Well, I think I might repeat myself here, but again, it's AI is not a substitute for clinical judgment, for critical thinking. We shouldn't look at AI as AI should guide our consult. So AI should be there to support us, right? And like with anything else, I think having using cross references with trusted content to potentially see, is what I see here correct? And it might be correct, but in light of the way things go, in healthcare, things evolve constantly. Nothing stays the same. Change is the constant. So I think reporting gaps, letting people know that it's good to actually confirm that something is true, and the way to confirm it is to actually cross-check references as well. And so that's very important to make sure that the CDS has a solid editorial process, that the people working at creating these documents or the information, the data, is observing ethical practices, best practices in data dissemination, all those aspects are important. I think from my perspective, that's usually what I tell customers when they would ask something like this, or clinicians.
And I would probably just jump in and add to that too. Like I completely agree with Fabian, and I think it just emphasizes also the importance of looking for drift in these models. And like for the generative AI models, they are not cheap at all to retrain. And so it can take 90 days and cost multiples millions of dollars to train these foundation models on data that medical knowledge doubles like every 75 days. So now you've doubled medical knowledge, and that's not even anywhere in the training data. And so there are approaches to point it at reputable sources. And if you can pull information from curated reputable sources, then you're not having to retrain the model every 90 days. And so there's frameworks to help do that, but just emphasizing the importance of garbage in equals garbage out. And if you can have good reputable sources going into these models or decision support, and there's a process for maintaining them over time, then you're going to get better results out.
Yeah, I mean, and that really highlights too, like system design. What are we using? You know, is it a standalone foundation model runs into a lot of difficulties with the missed gaps in knowledge or needing to be retrained, but having a system design that is actually searching a curated repository is perhaps a lot safer approach when it comes to clinical information. So, all right. I'm not sure. Let me do maybe one more, and I don't know if this will fit in our time, but what are some effective strategies for monitoring and mitigating bias in AI algorithms? For instance, should providers be required to regularly review and audit their AI systems for fairness and accuracy? I think we hit on this a little bit earlier about the importance of, you know, continuing to, you know, what the data that is used by the tool and continuing to monitor. I don't know if anybody else has any thing to add with this.
I just a quick aside, and then I'll defer to our experts, Scott and Dennis. But I just think it echoes on everything we've talked about today. Scott mentioned garbage in is garbage out, but I think this is a perfect opportunity for health systems to bring in their, you know, P&T committees or various clinical expert committees to really take that, like we talked about, multidisciplinary approach to help make sure that you're auditing the tools, make sure that you're reviewing the questions and the answers that you're getting and using those tools appropriately.
I mean, my bias is absolutely yes. They need to test for fairness metrics across the populations so we can have equitable kind of outcomes from these models. Healthcare data is especially just systematically biased. And has lots of historical biases in it. If you look at like EGFR rates, for example, labs have taken into account like race for years, and until recently that's been removed. But if that's the kind of data that you're training on, you want to make sure that you are having equitable outcomes for patient populations. And there's things that you can do to manage that and handle that so that in the end you have a less biased model than the data that was going into it. But a lot of that's on the very technical details of the development team. But I think you do need to monitor these because hospitals acquire new hospitals, they open new wings and rooms, and you see different populations. So drift is happening. And so you want to make sure that you're still treating your patients in equitable ways.
All right. And we have just hit the top of the hour. This has been great. This hour's gone very quickly. Thank you very much to our panel for participating today. And thank you to the audience for joining and for your questions. We really appreciate, it's been a great discussion. And I know I've learned a couple new things today too. So appreciate it all and take care. Bye.